Any additional corrections to the minutes? Hearing none, we'll accept them as approved by consent. And I will turn the floor over to Autumn.
All right up there. Yes, you say you might need to turn it for me. Figure out how to do that.
You could just pair over.
Perfect. All right. Thank you, Jennifer. So my name is Autumn. If you have not met me, or if those of you online do not know me, I am our cancer screening program coordinator and case manager. So normally I would give you guys some updates on like kind of what's going on in the program, but today I really wanted to share with you the 2021 incidence and mortality report for cancer in Maryland. Tried to keep it a little bit short to not bore you. I just told Jen it was like a 200-page document, so I wasn't about to share the whole thing with you. So this incidence and mortality report for cancer in Maryland was published just this past August. It's also posted on the MDH website. This is for 2021. The data in the report include cancers reported for the year of 2021, and they're presented as age-adjusted rates and number of cases and deaths, and are sorted by sex and race or ethnicity. And then, so where do we get these numbers? The Maryland Cancer Registry collects all new cases of reportable cancers diagnosed and or treated in the state of Maryland, and is our state's official source for cancer statistics. So, some context. Cancer is still the second leading cause of death, exceeded only by heart disease in the United States. The mortality impact, there's nearly 1 in 4 deaths, which is about 500,000 people who died in 2021 from cancer, which is about 1,600 people per day. The specifics for Maryland, there were 33,945 Maryland residents diagnosed with cancer in the year of 2021. And of those 33,000 diagnosed, 10,540 deaths resulted. So looking at even more specifically at just Maryland, and then we'll break it down by county. The top diagnoses for cancer by sex in the state of Maryland for 2021 was prostate cancer for men and breast cancer for women. However, the leading cause of cancer death in Maryland for both men and women is still lung and bronchus cancer at 2,294 total deaths in the year of 2021. Looking even more specifically, just at Garrett County, in 2021, there were 186 new incidence cases of any type of cancer. Of those, 84 resulted in death, which gives about a 45% mortality rate for Garrett County. The top 5 incidence and mortality cancer counts from 2017 to 2021. Female breast is the highest incidence. However, lung and bronchus remains the highest mortality. So if you can see for Garrett County, 92 people were diagnosed. I honestly can't even see that mortality number from here.
You can close that, Autumn. There should be a little X if you hover over the right corner.
Can I see that far? Thank you. Of the 92 diagnosed, 60 resulted in death, so that's about a 62.5% mortality rate for lung and bronchus cancer. So, all of that bleakness, what's the good news? Every county in the state of Maryland has a CPES program. That's our Cancer Prevention, Education, Screening, and Treatment program. That is the program that I coordinate. We work to navigate patients through the healthcare system, advocate for screenings, and get patients into primary care to get these screenings scheduled for them. Although lung and bronchus cancer has our highest mortality rate in Maryland, we now offer this screening. We instituted it this fiscal year. Our goal was to, I believe, screen about 3 people, and we are looking to screen about 10 already. So that's good news. Our CPES program screens for all of the cancer types that have the highest incidence in Maryland. So we offer lung, colon, rectum, and skin. And then our Allegheny Health Department is still our regional hub for breast and cervical. So far this fiscal year, we've had 9 referrals that have been sent to Allegheny, and of those 9, 5 people qualified and have been screened for breast and cervical cancer. And then our number of program outreach activities and our total, number of Garrett County residents screened has increased exponentially in the last 3 years. We have partnered with a lot of new providers. Our outreach team, Jamie's sitting right here, have just done a phenomenal job outreaching to other parts of the community to get this service really out to the public. So this is kind of what we're doing. If you want to see the full cancer report, you can find it on the MDH website. Questions? Just kind of wanted to give some updates on numbers, what we've been doing.
What was the website again?
It's on the Maryland Department of Health website.
Say that again.
The Maryland Department of Health website.
And what's that name? MDH?
It's just
Health.
mdh.gov.
No, it's health.maryland.gov.
mdhealth.maryland.gov.
Yes. Okay.
Does that have more county statistics?
Yes, it goes through each county in Maryland. I just did our county because we would have been here a while if we did all the counties.
Can you explain more about relationship Garrett County to Allegheny County regarding breast and cervical cancer screening?
Yeah.
I don't-
So we at Garrett County used to offer that screening as well. And a lot of people, there's a misunderstanding that that's not available to Garrett County residents. And it is. Basically the money, the grant funding from MDH was put in Allegheny's pot. So Washington County and our county uses Allegheny as a regional hub for funding because we weren't spending all of the money as well. So what Allegheny County does, if we have a resident who lives here, they basically pay through it through their funding. But they have contracts with facilities up here like Oakland MRI and a bunch of doctors, so where they don't have to travel to Allegheny County. Basically, the money just comes out of their pot.
What about the private docs? Private docs are a big part of this screening. And do they have to go to, how do you get Garrett County residents to be approved by Allegheny County to see a private doc in Garrett County?
Because Allegheny County partners and contracts with our doctors in this county.
Not you, but Allegheny County has a.
Yes, but I work directly with Ellie Folk, who is the coordinator of the program in Allegheny County. So if Jennifer Hare comes to me and she says, I need a breast and cervical cancer screening, what I do is call Ellie. I can even do the intake for the patient instead of them doing it over the phone with Ellie in Allegheny County, and just kind of coordinate their care and get them set up for screening here.
What has been the effect of this regionalization on the number of people screened through this particular program?
Stop.
Hello?
I think someone's off mute.
So I'm just now starting to kind of gather some numbers based on that. I've been in this position about 3 years. So now I'm starting to kind of keep track of how many referrals are being sent and how many have been screened. I don't know how much it's changed since
Yeah, I don't know that answer either.
before.
But there was a perception that it was no longer available. So our referrals and our screenings went way down when they pulled the administrative funding from Garrett County.
The timing was also very poor because it happened to coincide right when we went into the pandemic. And that created a lot of extra issues because all the nursing staff were being pulled for other activities. So I know that for the first couple of years, it was really, really rocky just trying to get the actual person like through an intake.
Yeah.
So I think it's really great that Autumn's able to do that, get that process started. I know we've had walk-ins, we've had someone reach out to us. So I think there's still an opportunity for us to probably communicate that a little bit better because we do a lot with CPEX, but I think with BCCP, we don't get the same level of advertising that we used to get.
Yes. Yeah. They
And-
do. Allegheny does some advertising that they share with me. So I try to like give it to our outreach team and put it out there and talk about it. Or if a patient calls and they are just interested in a skin cancer screening, if they're, a woman of age, I just kind of open the conversation. Like, have you had your annual mammogram? Have you had a pap smear? And talk to them about how that's available to them as well.
And this next month is a tobacco month, so we'll be dealing with CPEX as well. On the back of each of the flyers that we hand out to public whenever we go out to any of our events, I always put something separate on the back of our flyers, and I'll be sure to push the breast and cervical.
Okay.
It was something that we did initially whenever it was first, before this group was formed. It was just two of us. It was something that I had to push out through the outreach with the outreach team. And I intend to implement that next month in our tobacco.
I've personally seen this fiscal year, a lot more, I've been sending a lot more referrals to Allegheny County and working, closely with,
Because you send them to Allegheny County, but they're from here, so that you started to find more people in Garrett County eligible that have to be approved by. Allegheny
yes, they
County.
have to be, technically they have to be approved by Allegheny County, but I have worked with Ellie to be like, send me all of the forms, the consent forms that you need this patient to sign, send me your verification paperwork. So you don't have to do this over the phone, or you don't have to do it by mail. Let's just kind of cut out the middleman and I'll do it. So I've kind of just helped them with that as well. The basic understanding is that I'm just not paying for it. Garrett County's not paying for it.
What proportion of your referrals are made by the patient or client, and what proportion are made by the doctors in the community?
It depends on which screening it is. I would say for pap smears.
Yeah.
I'd say just off the top of my head, thinking about how many referrals and how we get them, I'd say about 80% are from the provider and 20% are from the patients. We don't have a ton of patients knowing when they need a pap smear. It's usually from a provider.
And then what percent of all pap smears in Garrett County are actually coming through CPAS, so that we know that the clients know of this financial benefit, but actually just go to their private doctor, get their annual checkup, and get their pap smear locally through the local system, rather than going through this state system.
Well, if they don't qualify for our program or not in need of the financial assistance, then they would just go through their primary care provider. We're just here to help them kind of, one, pay for the screening if they have, if they're underinsured or uninsured. And those who don't have insurance typically are sometimes a little bit lower with health literacy. So then we talk to them about other screenings that are available. So our program really outreaches to those who don't have insurance, are of low income status, maybe don't have primary care. So it's kind of a big full circle getting them involved in healthcare.
Before we had this arrangement with Allegheny County, what did a patient have to do to get cancer and screening? Cervical and mammogram screening. Did they have to fill out papers and do all this stuff you're talking about now?
Yep.
Yeah.
Okay.
The process hasn't changed, just where that process takes place.
Okay. So for the patient, it's not really any different. It's just how it's paid for.
Pretty much, yeah.
Yeah, pretty much, instead of them having to pay out of pocket. Because a lot of people will not get a screening at all if they have to pay for it out of pocket. If they have a copay, co-insurance, deductible, whatever, they're like, I'm not getting it because I don't feel like paying for it.
We just need to make it as easy as possible, because people are reluctant to do it in the first place. It's an uncomfortable thing to mentally to have to deal with. And
That's kind of what we've been trying to do. That's why I work so closely with Ellie. I'm like, instead of mailing them all this paperwork that's going to confuse them, send it to me. I'll print it out. I will bring them into the office in person, fill it out with them. Our clinician up here in personal health does pap smears and order mammograms. So sometimes we try to connect them with her. Some of them even already personally know her because they've seen her for other things. So we set up transportation for them. I can do a one-on-one with them to go over their prep instructions. It's just kind of, again, it's a full circle. There's a lot of little moving parts that go into it to make sure they have a good understanding of what they need to do.
I think that one of the big things that is really different with BCCP is not so much on the client end. Now that we have Autumn, who by the way is a superstar. So I would also recommend that you reference Jennifer's status of health and annual report, because I think it really showcases, like when you look at like the My Garrett County data, like the change year over year and the number for the CPAS program and some of the others. I think BCCP, one of the challenges is just a part of it out of our control. So like when it comes to advertising, we used to have thousands of dollars to actually promote BCCP services directly to the patient. And I do think that in some of these programs that makes a big difference, because it's not only the provider like saying, oh yeah, by the way, when you leave, you need to go do all these things. And I think that process has also changed a bit.
Mm-hmm.
I think it's much more hands-on now than it used to be. And that might be one of the reasons. Autumn might be able to speak to that.
Instead of the providers, typically, especially this year, instead of the providers telling the patient, like, hey, here's this program and all of this information, look into it.
Like take it and leave.
Yeah, the providers contact me and they say, hey, I have this patient, they don't have insurance, these are the screenings they need, will you contact them? And I do. I call them and I say, hey, your provider sent me your information, I hope that's okay. He's recommending you to have these screenings, let's talk about it a little bit more. Like, what's your insurance status? What are your reservations about having your screening? And then just basic education on why you should be screened.
And I think if there's any interest in the preview, I don't know if Caroline's on the call, but Caroline Evans, our WIC director, used to be the VCCP coordinator for Garrett County for many years. And like I said, I think that having that money that we were able to spend locally made a really big difference. And we were able to do a lot with that. And I think for me, that's the big thing, is just because we don't get a ton, like we don't get the same level of, I would say, outcomes with what we do in terms of outreach, because it's not controlled by us for that particular program. Like, we do great outreach, but we don't have the same level of resources. We don't have the money to attach to it. Like, we can't do mail. Like we just don't have the funding for that particular program.
Yeah.
And we have to rely on another health department to really do that.
Like planting little seeds. Like in our CPES brochure, I still have breast and cervical listed. So if someone sees it and they have questions, I'm like, great, we can talk about it and I can explain it more. But I don't like just leave it out of our program.
Like, we had a referral this week that came through for the VCCP program, who had no idea that we had the program, like just wanted to know generally. And that's just not something that happened when we had the money to do that.
I do think it's important to compare the numbers we have now versus before the change took place. Because if we're down, we need to do something to improve it.
It's possible that we may be down in breast and cervical. I'd have to look at that, especially since the regionalization. But I do know that as far as long skin and specifically colorectal, those numbers are significantly up.
Like,
I understand that, but I'm not a female, but I just, from having treated females, they don't want to have this done to start with. It's unpleasant, somewhat uncomfortable, and I think we need to push it. I mean, cervical cancer is a preventable disease, pretty much, and we need to get as close to zero as we can as far as rates.
Well, the other thing I'm thinking about for rates is, even if they're not going through the program, I don't know how I could track those in Garrett County who, get. Do you have those kind of numbers? Like, just who in Garrett County gets pap smears, mammograms, even if they're not related to the health department? I didn't. Yeah,
Information's not out there.
I didn't think so. That's what I'm wondering.
If you look into it, probably the same pathologist company does 80% of the pap smears in Garrett County, just my guess, through the hospital system. And they would, same with colorectal cancer. It'd be interesting to know how many patients actually go entirely through the private sector. This little bit of financing on the side, because all the docs take their patients, give them a service, and try and recover the money afterwards. They don't turn people away at the door because they don't have insurance. And so you might find that 50% of the patients 50% of men and women in Garrett County of eligible age. And the trouble is income, this whole thing of putting income into whether you get medical service or not. And of course, is the spectacular exception of American healthcare system.
Yeah, if I had a choice, I wouldn't make that a rule, but I can't.
And so you don't know how many people actually are falling out because of that American system that we impose on trying to get rid of cervical cancer and colorectal cancer. We're not seeing that. We don't know how to find that.
Unfortunately, no, that's a much bigger issue.
Obviously, the private sector doesn't come to meetings like this. And so it's very hard to.
That's why I've approached them directly. I usually quarterly do outreach to our private providers and talk with them just one-on-one if they'll have me, because I know they can't come to these meetings.
I did pull up the assessment, so Jennifer bought us some great data, so we do have some of this. So we did talk about this briefly. I can't remember if it was last month or a couple of health planning councils ago, but we do have reference data available for cervical cancer, breast cancer, and colorectal cancer. Lung and some of the others get lumped into broader categories of disease, so we don't get the specific screening numbers on those. But those are available in the Garrett County Community Health Assessment, and then it is also in the zip code indicators report. Many of these, because the counts are so small, are suppressed, but usually for Oakland and sometimes for Grantsville and a couple other communities, we do have even zip code level data for those. But the BCCP data in particular, Autumn, I don't know, like I'm sure that you have access to that, but is there a public report on that by county?
Not
I don't think-
not a public one for just breast and cervical. There's just the cancer incidence. And they'll break it down a little bit based on the highest incidence. That's why you saw breast in there a little bit, but not just for that specifically, unfortunately.
Yeah.
Now Allegheny might have their own, but I don't know if they keep track of who are Garrett County residents. That's why I've started to keep track of it.
Yeah, well, and the counts are so small, they're probably suppressed, and they wouldn't be able to actually report them.
Yeah.
Report.
I mean, I've only been able to refer 9. I mean, over 50% qualified in the screen, but you know, only 9 out of however many are in Garrett County.
When a patient is identified as being in need of financial assistance on any of these cancers, do you pull them into all the cancer screens and support services that CPES is able to do?
If they are willing to do so and are eligible for it, yes. So if
But the eligibility is the same for all of 4 or 5 cancers.
no, not
Like a screen
necessarily.
for-
We've had
they're
some individual, I mean, you don't get a lung cancer screening if you've never been a smoker. So if they're due for a colorectal cancer screening starting at age 45, we talk about that. And then I ask, do you have a history of smoking? If they say no, I don't approach the lung cancer module because they don't qualify for a screening. They don't need it. Or if they're under 40, but they complain of a breast lump or something else going on with the breast, they're not technically due for a regular screening. That would be a diagnostic imaging procedure, but they may be able to have that done because they're having an issue. Like I think I had a 19-year-old screen for colorectal because they were symptomatic. So everything that they're, eligible for and willing to do, yes, we do.
They don't go together as a unit in any of these services, though. They're all screen. Where do you go for skin screening?
They can go to either Mountain Laurel Medical Center or they can go to Western Maryland Dermatology. Or they can actually see our clinician upstairs, Jessica Carey. So whichever is most convenient location-wise for them.
And then the colorectal.
If they're doing a colonoscopy, we contract with all of our general surgeons here. That would be Dr. Walsh, Lopez, Tannenbaum, and Dr. Doherty as well. And then for the facilities that we use our Garrett Hospital, Potomac Valley Hospital, the Surge Center in Cumberland, Maryland, and UPMC Hospital. So 4 different locations, depending on where the patient prefers to go.
Do you know if there's any move towards, for cervical screening, self-screening?
In the state?
No, as far as I know, there's no move towards that at this time. There's been some talk about it, but I don't think that there are steps being taken to do self-screening. I think there's a lot of concern with clinicians for adequacy of specimen collection.
Just wanted to comment on that real quick. I'm sorry, this is Michelle Dixon. I'm from Mountain Laurel. Just from what we've been seeing for our metrics and reporting, we're looking at 2027 that they're talking about changing, that self-screening is potentially going to be an option.
Who's making it an option? Mountain Laurel.
Yeah, I'm not sure. We have not talked about that in our personal health clinic yet. We haven't really approached that. So Michelle, is that just for Mountain Laurel?
No, they're talking about changing the guidelines. Potentially 2027 is what we have heard recently for upcoming metrics for UDS reporting.
Great, that's news to me as well. Any other questions, comments? Honestly, I just want to say thank you for the conversation. Other meetings that I've had in the past, it's just crickets and I feel like I'm not doing anything. So I appreciate the conversation. So thank you. John, how do you do that? Okay. This?
Okay, I'm not going to walk to the room to say that Martin is going to take over the conversation now to talk about some subcommittees, ad hoc committees we'd like to start.
Thank you, Jennifer. Good morning, everyone. Martin Kraska. I wanted to take some time today, just kind of get an open conversation going and then request feedback. What we'd like to do is start two subcommittees, especially with everything going on now with the AHEAD model will be one committee. And then additionally, the Rural Health Transformation Program. So what we're kind of thinking how we would like to see these committees run, meet monthly, and then report biannually back to the Health Planning Council. So we're really just kind of wanting to just kind of get feedback today just to see what kind of stakeholders we could get involved in these committees, just with everything coming down with not only the Rural Health Transformation Program, but then, like I said, the AHEAD model. Part of the AHEAD model, there will be a population health action plan. So we really think we can take some time with these committees to kind of go over what that can look like. And then also just going there, kind of, monitoring these programs and see what kind of funding could be coming with these programs. So just kind of want to open it up to the floor and see what everyone would think.
And the crickets are back.
Dr. Schwab. No, Dr. Schwab's getting ready to talk.
I don't really understand what committees you want to create. Can you explain that?
So one with everything coming down with the AHEAD model, and all that with, because there's a lot of going to be funding sources through that. And then also part of it, like I said, was the population health action plan that will have to be developed. So it's really just monitoring that. And then also with the Rural Health Transformation Program, there's going to be a lot of funding sources. So really, we just want to bring the stakeholders that are going to be involved under these programs together, just to discuss and then kind of track what it's going to be going on as well.
I think you're assuming we all know what the HEAD program and the transformation program. I have no idea what you're talking about.
Oh, so yeah, we can discuss that as well. The Rural Health Transformation Program, we discussed it, I think, at a couple meetings prior, but it's basically a funding opportunity for rural health programs within rural counties in Maryland. Maryland was awarded, I think, around $168 million in funding. And it's really just to kind of expand access to care, different investments in technology in rural communities, especially in the healthcare sector. I know there's a big emphasis as well as food as medicine. And that's all part of not only the Rural Health Transformation Program, but then the AHEAD model as well. And it's really to work together with the Population Health Fund, and then deliver basically more access to care as well. So I know there will be a lot of different stakeholders involved, not only Mount Laurel, our hospital systems, the health department. So we'd really like to take the opportunity. That's why we want to develop these committees, just to keep up to date on what's going on and potential funding sources as well.
We thought the smaller groups, as the smaller groups met on a monthly basis, there could be more interaction for input. Some of this is landing on the health department to help coordinate what programs we want to have, the metrics that the AHEAD model specifies, 6 different metrics that we are supposed to be making an impact on. So we need the stakeholders involved in the community to give us input on what will make a difference in the communities, what will affect the patients, and those types of situations.
This, what was the program there that where they cut back medical assistance severely, and it just about didn't get through Congress in the great, beautiful, big, beautiful bill? There was one vote that swung it to taking away medical assistance. And instead, they promised some number of dollars to keep from shutting down rural hospitals that were going to be so hurt by the cutback in medical assistance. So they put in this public health type program in between there, hoping that hospitals wouldn't be shut down just because there was no money to pay for the patients. It's went through Congress, and we now have the big, beautiful bill, less medical assistance available to the clients to pay for their services. And it's never been clear to me. They cleverly spread that out over 5 years, so it's not clear how quickly the removal of funds for medical assistance is going to happen. But everybody is scared to death. And fortunately, we have a very strong rural hospital, but there's so many other hospitals that depended on medical assistance just to stay open. So there's a lot of mystery in that, how effective all these public health type population measures are going to substitute for the lack of funding for patient services under our current healthcare system. So, but you can't answer that. Nobody knows how quickly people are going to be hurting. And with any insurance system, it's not 100% effective. You don't use your insurance unless you need it generally. And so people don't realize who's going to be hurt. And then the people that have the need for the medical care suddenly find they can't pay their emergency room bill, can't pay for their surgery, can't pay for their second step on their screening test. That is, that's something I didn't get past how that's going, where the state was paying for the pap tests or paying for the colonoscopy. But if there was a single polyp, then the state would no longer pay for evaluating that polyp as to what it was, whether it was cancer or not. So, or if it was cancer, what the heck do you do with it? There's a disconnect between the public health aspect, screening, and the actually taking care of patients who need care. So I don't know how that's going to turn out, but it's a little premature to imagine that we can anticipate what the effect of the big, beautiful bill is going to be, the reduction of medical assistance, and what a percent of that healthcare, Garrett County's healthcare system is dependent on medical assistance. The only thing I can imagine is that, well, they're throwing money at Mount Laurel type centers across the nation as being the option, that they're saying, well, anybody who's poor can go to Mount Laurel type centers. And that's not a solution for a lot of people in the United States. And this disparity between caring for people who have insurance and then people who don't have insurance go into a different system, which in Garrett County is a good system, but because of Mount Laurel's existence, but for a larger area, a lot of people are getting left out. Tough lecture, sorry. I didn't get
I think that's, and to your point, I think that's why it's important that these committees that we're going to be forming to kind of monitor these programs where, like you said, there's a clear like access to care. And so I think it'll be important under both of these programs, the Rural Health Transformation Program, the AHEAD model, that there are sources of funding. That way we can work together as stakeholders and bring that funding back to our communities to better serve patients.
So what we're asking for today is discussion, obviously, but also a vote from the Health Planning Council to form these committees.
Yes.
If there's a motion, we would entertain that.
Motion to form
I would second.
the ahead committee and rural transformation committee.
Yeah, I would second that. This is Michelle from Mountain Laurel.
Gonna say I would second too. And be interested in the transportation committee. I would be.
Yeah.
Morton's like, Amy's gonna do the transportation.
Absolutely.
Specifically with the Rural Health Transformation Fund, there, mobile health is a huge part of that. And just so you know, Garrett County is the regional hub. We've been designated as the regional hub to push out any requests for proposals and any propositions for Garrett, Allegheny, and Washington. So we definitely need your input on that part of the committee. So we have a motion and a second. Any other discussion?
Could we discuss committee membership and board membership?
Absolutely.
And board membership is separate from committee membership, so that the fact that, well, whatever fact, committees go far beyond the board, but on the other hand, effectiveness is a whole nother question, and we can't discuss that here in this time.
That's an excellent point. Just, you don't have to be, well, you don't have to be on the Health Planning Council to be a member of the committee. Of course, Health Planning Council meetings are public anyway, and the committees could be that way also. Is there something else you'd like to discuss about? You want to like start brainstorming who you want on the committee, or? Yes, on that.
I'm too old to understand what the heck this ahead program is. I mean, they've invented this new set of letters. New set of things they're gonna do. It's just public health care, and I don't see what the hell it is.
Well, the ahead model is taking Maryland's all payer model and making it federal more than
Okay,
more than
all payer,
anything else.
Maryland's all payer model. They're sort of going away from it. They're dropping it.
Yes, they're taking
So-
what Maryland did with the all payer model and turning it in federal to nationwide into the ahead model.
But they're also changing what Maryland has
Yes,
to something different, which we haven't experienced yet.
correct.
And we're got our fingers crossed on that one.
Yes.
And so this is part of the thing where they take it away from you and say they're going to give you something better, but usually it's down 50% or 70% or 80% in terms of investment in the new system. And then they start doing whatever they want to do. A little bit here, a little bit there. Just find out who's making noise, who wants to write a grant, because they can do that. And then you have all these dozens of little grants all over the place trying to keep everybody calm and
Well, that's
quiet.
part of the reason why the ahead model is forcing collaboration. So we are required, the health department is required to work with a hospital. We're required to work with Mountain Laurel. Not that we don't want to, but that's a requirement that we all have to work together on this public health accountability plan. And so that's why we use this group and then a subcommittee of this group to get that collaboration and get that input.
Theoretically, we've been doing that all along. They're all here on the council. We decide we're gonna work on a new area. Somebody writes a grant. Everybody signs into it, but they're not really part of it.
It's just that this is so prescribed that it's such detail work that it's difficult in this setting to do the detail work that's required for, especially for this population health accountability plan. Bob, you have your hand raised.
Yeah, good morning. So I think that's great that Garrett County is going to be the regional hub. Normally that goes to Allegheny County. It's always based on geography and not based on the work that needs done. But what I would ask is, are you having this similar discussion with the LHICs in Allegheny and in Washington County? So is this going to be a regional committee, Martin, or is this going to be a Garrett County committee, and then you'll get together with the Allegheny and the Washington County? How do you see that as playing out?
So I think our initial thoughts was just specific to Garrett County. But that's something though, like you just said about the regional approach. I mean, that's something we could discuss as well, as a committee, because it will impact the whole state. So I think we'd be open to.
As
Oh,
far
go
as
ahead,
the,
Jennifer.
as far as the regional aspect
Mm.
of it, it's only for the mobile health part of rural health transformation.
Mhm.
So I think the Garrett County subcommittee would focus on Garrett County, all the Garrett County issues that are impacted by rural health transformation. So
Mhm.
the food as medicine, the nutrition education, the access to care, mobile health is just a piece of that. And that's what we are the regional hub for. So we can, and then, so if that committee is communicating with me, and then I'm communicating with the other two health officers, and, I can tell them what we're doing with our LHIC, and then they may do that with their LHICs also, so.
Okay, thank you. And one of the things that you may want to consider is regionally there's a pretty strong group that is the emergency prep folks. That Eric Savetnik would be aware of those groups, because they're all the hospitals are represented, all the emergency managers on all the hospitals, most of the FQHCs are represented, as well as the health departments and EMS. And I think EMS is a big component too, because that is just such a hard program for people to operate now, and access to care is really important in those emergency settings. So don't forget to bring those folks in.
Absolutely.
Absolutely.
Lisa.
Yes, I had just a question about the rural transformation grants. I've heard about them and they've gone through the health departments, but I don't understand exactly how. So are they different parts of that grant, and they're going to be divided between the 3 counties? I mean, each county is going to take a different head of one of the parts of the grants, or exactly how? Can you explain a little bit more about how those transformation grants are being distributed across the? I'm with the extension. I work across Washington, Allegheny, and Garrett County. So I'm just curious to know.
We don't have a lot of those answers yet. So Maryland was awarded 168 million. Some of that 168 million that they received or will be receiving, they are right now, they had to resubmit their budgets. That process, I think, is probably due by the end of this month. So they haven't been real formal yet in saying this group is getting this group is getting this. They haven't done that portion yet. That still has to be approved by CMS. So some of that, though, MDH will be retaining. They're putting out some statewide grants and doing their own procurement and their own divvying out the money, specifically with the food as medicine portion. Right now, we're told that most of that will be handled very centralized. The nutrition education funding is coming to each individual health department. And then it's up to those each individual health departments to, I haven't seen that. I don't know what the conditions of award are going to be for that yet. I've seen nothing other than that the nutrition ed money is coming to the health departments. Mobile health, they've asked us to take a regional approach to it. And so we will be issuing requests for proposals or applications regionally. And then anybody that can provide services in that region will be able to apply for it. And then, like, if Garrett is the regional hub for it, then they'll just be paid for out of Garrett. If that makes sense.
Thank you very much.
Any other discussion? So we have a motion and a second to form these 2 subcommittees. All in favor, say aye or raise your hand.
Aye.
Aye.
Any opposed? Okay, so we'll form the two subcommittees and we'll start, please, if anyone has suggestions or wants to volunteer for the committee, please email Beth and CC Martin if you can, if you have his email address. Maybe Martin, put your email address in the chat. And so if you want to volunteer or you have suggestions on who should be on the committees, please email those two people and we'll get them up and running. Okay, so that leaves us with agency updates. And I'll start there since I'm already talking. We have gone through the process to hire a new medical deputy health officer. That person is still being vetted by the state in 2 weeks. Hopefully they will be able to start about mid-February.
Is that full time?
No, it's probably about a 10-hour-a-week position,
It's just for Garrett County.
just for Garrett.
And what is the basic educational requirement?
They have to be a licensed physician.
Which would of course include DOs, but not nurse practitioners.
Not a nurse practitioner. Has to be a doctor.
How many applicants did you have?
We had 3, 1 declined the interview, and we interviewed 2.
And are they going to be operating on by electronically, or are they going to actually be here in Garrett County?
It will be both. They are a Garrett County resident. The one we chose is a Garrett County resident. And they will be present in the building and also teleworking.
For 10 hours a week?
Yeah.
Are they currently members of the medical staff?
I don't have any doctors on medical staff.
As applicants?
Hmm?
As applicants for this position?
They were not part of the Garrett County Health Department.
They could possibly apply to the medical staff in order to be part of the medical community.
Oh, they're part, you know this person. I just can't say their name yet. You know this person. Because I can't even offer the person the position until they've been vetted. So I cannot say this person's name now. Nor should I give you any additional clues. Are there any other agency updates? I want to welcome Michelle Dixon. This is your first Health Planning Council. Welcome as the new CEO of Mountain Laurel.
Thank you. It's good to be here.
Any other updates to give? All right. Have a motion to adjourn?
So moved.
Thank you. See you next month. It's not Dr. Schwab.
It's not me.